Well, absolutely wonderful. We are honored and blessed to be able to have Dr. Go Wakabayashi give us a state-of-the-art lecture on something that he is one of the world's masters of, which is advancing the field of minimally invasive liver surgery. He is the immediate past president of ILS. He is an absolute pioneer of laparoscopic liver surgery, specifically in Japan. And one real highlight of his career is that he was able to have the government approve reimbursement for minimally invasive liver surgery within the country of Japan. And that's something that he is very proud of appropriately. In 2014, he was the Congress chair for the second consensus conference on minimally invasive liver surgery. And this is one of the most highly cited papers in the field with over 1,300 citations. Dr. Wakabayashi, we're honored that you're able to give this talk. I know you really wanted to be here in person, and obviously the world has put some barriers to that being able to happen. But with the beauty of technology, we'll do the best we can. Thank you for submitting your talk, and we can play it now. Thank you, Chris.
It is my great honor to give a talk at State of the Art lecture of HPBA 2021 in Miami. Please accept my apology. I cannot come. And I'm supposed to give a talk on the future, but I rather talk from my perspective. I have no conflict of interest. When I look at the Google Scholar, 2 consensus meetings have been cited over 1,000 times. And systematic review for the basis of a consensus is also cited a lot, and the Southampton guideline papers, followed by 10-year experience of our institution, and long-term colorectal liver mets, and hepatocellular carcinoma, and systematic review for major hepatectomy. And this is our original procedure, laparoscopy-assisted major liver resection using hanging technique, and the long-term results comparing propensity score match of colorectal liver mets, and so on. I'm going to summarize those papers to give some idea how I have come this far. Of course, when we started lap liver resection for the first time back in 1995, and for the next several years, we had fears for bleeding, and we stressed with poor ergonomic. Then we thought robotic assistant can be a good solution, but it was not. I performed 28 robotic HPB surgery, including 4 cases of robotic assisted hepatectomy. Actually, these cases, the world's first robotic series, according to intuitive internal record. To be honest, I didn't like the robotic hepatectomy because evident learning curve existed, and I didn't see any benefit. But in even that time, I thought pancreatic jejunostomy can be done by robotic assistance nicely. So after 2 years after the Daniel Silky and Olivia Subban published laparoscopic donation from mother to child, left lateral sectionectomy, we followed that 2 years later, but we used a hybrid technique because I was not so sure if I could perform a pure laparoscopic left lateral sectionectomy safely. Actually, this was my last open donor hepatectomy because the safety is the most important thing for donor surgery. But I felt also the guilty when I opened up abdomen like this for a healthy volunteer. So we used this technique, laparoscopy-assisted hanging technique. We did the major hepatectomy for liver cancer. Then we used this technology to donor hepatectomy like this. That time, pure laparoscopic donor hepatectomy was performed by Olivia Subban and Ki-Hoon Kim only for left lateral sectionectomy. But other right hepatectomy applies a laparoscopy-assisted way or hand-assisted way. But big news came to us 2012. This gentleman died on the OLR table due to the massive bleeding from a hepatic vein or vena cava. They applied laparoscopy-assisted or hand-assisted donor hepatectomy for the right side of donor, right side of grafting. So we thought small incision hepatectomy might be dangerous compared to pure laparoscopic hepatectomy. So we started the pure laparoscopic donor hepatectomy 2012 December, and we quitted the laparoscopy-assisted donor hepatectomy. This is a laparoscopic-assisted donor hepatectomy, and this is a pure laparoscopic donor hepatectomy. we realized that operative view is much better. And due to the pneumoperitoneal pressure during the parenchymal transection, you can achieve a bloodless parenchymal transection like this. You expose mid-hepatic vein like this nicely. So we compared first 40 cases of a laparoscopy-assisted donor hepatectomy versus later 14 cases of a pure laparoscopic donor hepatectomy. All of cases I did myself, so there's no learning curve existed because my learning curve period was already finished when we started lap-assisted donor hepatectomy. And I realized that operation time is longer in pure laparoscopic donor hepatectomy. It's understandable. And graft retrieval time also 4 minutes longer. That's also reasonable. But amazingly, blood loss became 1/3 of laparoscopy-assisted donor hepatectomy for pure laparoscopic donor hepatectomy because parenchymal transection is done under pneumoperitoneal pressure in the pure laparoscopic donor hepatectomy. So we knew from an animal experiment, pneumoperitoneal pressure reduces backflow bleeding from hepatic cut surface.
So this is a proof of concept by the clinical data set.
Every new innovation has to have a tipping point like this. So we started very early, like innovators, early adopters. Lap liver was like this. And I realized that lap liver may be gone or is going up like this. So what we need, of course, randomized control trial is good to encourage those new innovations to be spread. But it will be very difficult to conduct randomized control trial for a liver resection. So we chose a consensus meeting, to propagate this surgery safely in the world. This was the first international consensus meeting initiated by Professor Joel Well in Louisville.
This first consensus meeting has a significant meaning because the surgeon who performed lap liver surgery was not so many. We knew each other by names, but for the first time, we saw each other in person. Then we became friends.
And I thought maybe we're going to host another consensus meeting 6 years later. This is a postgraduate student animal experiment. When you increase the pneumoperitoneal pressure, you increase the portal vein pressure. But when you increase the pneumoperitoneal pressure, hepatic vein diameter is going to be reduced. That means the soft liver can be shrunk by pneumoperitoneal pressure. And also, when you perform laparoscopic liver resection, your camera go through navel bottom, then you see hilar plate in front of you. That's the starting point of a liver resection. And also, you can see even behind the liver, adrenal gland, vena cava. That's a very bloody area. But in contrast, when you perform open ventral approach, it is difficult to see behind the liver. And also, as I said, due to the pneumoperitoneal pressure, hepatic vein bleeding is almost stopped. Like even you expose the mid-hepatic vein like this, if you make a small hole, it won't bleed due to the pneumoperitoneal pressure. And also, liver resection can be done in a kind of small abdominal cavity. You can rotate the liver to make a right hepatic vein higher than the vena cava. Then right hepatic vein pressure is going to be reduced. Then you have a less bleeding. This is also from a Louisville consensus meeting. Minimally invasive surgery is really minimally invasive, but for sure, better exposure because liver is surrounded by the rib cage. When you place a camera around the diaphragm, you see everywhere around the liver. So I have come to this conclusion. Lap liver resection is superior than open liver resection because better exposure and less bleeding due to pneumoperitoneal pressure. I just wanted to share this idea among liver surgeons around the world. So we invited 43 expert liver surgeons, including open liver surgeon as a jury. This paper is a very important paper. It's a milestone paper because it is an independent jury-based recommendations. So those jury led by Steven Strasbourg sitting in front of us, and we propose a recommendation. Then they, change, modify, correct, and comment, and we published these papers. It's already been cited over 1,000 times. For this jury's recommendation, this systematic review, Ruben Syria used to be my fellow. He stayed with us 6 months just before consensus meeting in Morioka. He did a very precise systematic review, subtracting, removing a duplicate, and he counted over 9,000 cases. So he also did a final plot analysis and also divided into the liver section into minor and major, and even minor and major. Overall complication, estimated blood loss, transfusion rate, hospital stays better in lap liver surgery, even the major overall complication rate, estimated blood loss, hospital stays better in lap liver surgery over open liver surgery. And also he counted mortality from the literature. So 37 cases are reported among 9,527 cases. Of course, this has a reporting bias, but we know why patients die after the lap liver surgery. So during that 6 years between two consensus meetings, Evolution has done over 9,000 cases published, the conceptual change, causal approach, new operative and breeding, inflow occlusion, Pringle, and we have a name. We named it like a parenchyma sparing anatomic resection and also pure laparoscopic hepatectomy. So Morioka consensus was a big project. It published about 20 papers around that, and also including 6 papers, systematic reviews. Our moderator, Julie Harren, also published a nice paper. My colleague Morris also published, this systematic review. Then the lap liver surgery might be better for a cirrhotic patient with ascites patient, or than compared to open liver section. And Julie published in the futuristic simulation navigation. This is IMMOR. So we have a lot of information when we perform a lap liver surgery. That's very beneficial. So thank Pierre Adam Clavian. He gave an editorial just after our paper published. So in summary, this impressive and thoughtful exercise was well prepared and discussed over an intense 3-day period, laying the basis for our most up-to-date understanding and assessment of LLR and its future direction. Thank you very much. But the reality was, every night we had a party, drinking, talking, it was fun. It was almost a dream at this, we can't do this anymore. I mean, at least COVID, due to the COVID pandemic. However, I have to emphasize the most important message from the Morioka consensus is to protect patients from this new surgical procedure by doing these 3 things: prospective reporting, a registry for transparency, and also difficulty scoring system to select the patient. And we have to create a formal structure on education. So following that recommendation, we started online prospective registry in Japan and accumulated number over 8,000 cases like this. And also we shifted that registry into a national clinical database, and it was published on Annals of Surgery. And the penetration rate of lap liver surgery in all over Japan, 2017 was 25%. It's still increasing. And mortality rate is decreasing, as we can imagine, because, operative mortality for OLR and LLR. LLR looks better. Mortality is reduced than OLR because, patients are different. So we now performing propensity match comparison using the data 2018 and 19 and 20. Every year in our country, 25,000 liver resection is done. So it's going to be a big data, and we can see. So another way is to select a patient by difficulty scoring system using a difficulty scoring. This was published before the consensus meeting, and it was discussed at the consensus, and this was up version index-based difficulty score. We wanted to publish this difficulties updated version in the main report, but reviewer told us that you need to have a validation study. And we did different for validation study using Japanese cohort, French cohort. So even the comparison, the IMM score and this Iwate score. And my team also published a different aspect of difficulty score, including platelet counts and the BMI. That is also good, correlates nicely with surgical time and blood loss and length of a hospital stay. So I think a difficulty score has an important meaning for this newly developed surgical technique. So Mo Abhiro has a great leadership to host a Southampton consensus guideline meeting in Europe. So even though I was an expert, but I was a member of a validation committee. So this is also another milestone paper. By the way, long term, what about the long term of lap liver surgery? This is our data. So 5-year survival is over 60%. That's nice as a liver cancer. We also use a Japanese multi-institutional cohort study to see a propensity score match for hepatocellular carcinoma. And blood loss is less for lap liver. And operative time was quite similar. Length of hospital stays is shorter, and mortality is quite similar. And also, this is a collector liver mets, and long-term survival, disease-free survival is similar. And hepatocellular carcinoma, same, and blood loss is less, and overall time is longer, but the length of hospital stays is shorter, and the morbidity is less in lap liver surgery for hepatocellular carcinoma patient. Mortality is not different. Long-term is also similar. Disease-free survival is also similar. And this was first randomized control trial from a single institution. Again, complication rate is less in lap liver, and the hospital stay is shorter in the lap liver. Long-term is also similar. And the first source, Asmund Fredland, I was a first opponent for his defense, and second opponent is Professor Keith de Jong, at that time editor-in-chief of British Journal of Surgery, and of course he did a great presentation. But I gave raise obstacles to a randomized control trial. What about the ethical consideration? Because new hypothesis on the tumor size, number, location, patient accrual, and the patient preferences. Also variability in the surgical proficiency and technique. They did that. They used 8 expert lap liver surgeon and compared, their technique. Bismuth, good knowledge of the anatomy is a prerequisite for modern surgery of the liver. Yes. This was our first case to perform a laparoscopic limited anatomical resection for centrally located hepatocellular carcinoma in the cirrhotic liver. So, central bisectionectomy can be too much because remnant size is not so much, and also hepatic reserve is no good. So I realized that we can perform a medial sectionectomy with ventral side of anterior sectionectomy. This is kind of, now we're using this technique, like using a Grissom and Pellicule approach. So this is a resected specimen, looks like an enucleation, hepatocellular carcinoma located at the center, and with a good margin. This is anatomical, resection, medial sectionectomy plus ventral anterior sectionectomy. So we've been doing this type of surgery, parenchyma sparing anatomical liver resection with full laparoscopic approach for last several years. So the number is over now 160 cases. We published this paper. Pre-operative simulation is important and also volumetry is also important. You have to identify which greason pellicle to be clamped and dissected. We do everything from the hilar plate, because even segment 8, root of a segment 8, G8, is only one couple centimeter deeper in the parenchyma. You can open up a parenchyma from the hilar plate, then you clamp it, then you see a nice demarcation line. We routinely use ICG negative staining, not positive staining. Positive staining is terrible, difficult. Negative staining is much better. So this is how we perform anatomical resection. ICG negative staining, and also you can compare the area to be resected. We do pre-operative simulation and intraoperative navigation using this pre-operative DICOM data. This is Quino's grave, and it clearly shows hepatic vein running the intersegmental sectional plane. But the problem of Quino's segmentation classification is you can't see the border between 5 and 8, 6 and 7, 4A and 4B, and 2 and 3. But Takasaki, a Japanese liver surgeon,
proposed a cone unit concept. And this is very practically good, because you ligate a third order portal division, that means the greason and pellicle. Then you have a small part of the liver that's called a cone unit, looks like a cone shape. So you can add or remove this cone unit to cover the area to be resected for liver cancers. So this is good for limited anatomical resection. We routinely use this for our technique.
I'm going to show you one case, 60-year female, hep C, hepatocellular carcinoma. She's a Japanese witness and solitary hepatocellular carcinoma, mainly segment 7 and segment 6, one cone unit. And she's a virus-free, child PUA, hepatic reserve is knife, tumor is centrally located. And you can see this is crowded process, segment 7, and the yellow, green is one greason pellicle over segment 6. That's the subsegment of a greason over segment 6. So you can just ligate 3 greason to perform a monosegment 7 segmentectomy and segment 6 subsegmentectomy for this hepatocellular carcinoma. We routinely perform Pringle maneuver. When you take a greason pellicle, it was also Pringle, and you pull the Pringle tape as if all the greason pellicle can come from inside from liver parenchyma. This is G1 and right side caudate row. It's caudate process is now clipped and divided. Usually once you divide the G1, you have a more space to see back side of a posterior trunk. So this is a G7. So we can tape a G7. Then it's divided, not divided yet. So this is posterior trunk, I mean the G6. The G7 is now clipped and divided. But we knew from pre-operative DICOM data, G6, 2 branches. So this is the first branch. It's in charge for the tumor bearing area. So we can perform this segment 6 subsegmentectomy only. So we can preserve other segment 6 area. So this is very much parenchyma sparing, but still anatomical resection. So whole the right liver is mobilized. And now we're trying to expose anterior face of the vena cava by cutting a short hepatic vein and inferior right hepatic vein. Inferior right is now stapled, divided. Then adrenal gland is detached. So finally, vena cava ligament is taken. And it's clipped for safety. Sometimes short hepatic veins are contained in hepatic vein, vena cava ligament. Then we approach a root of a right hepatic vein. So I asked the anesthesiologist to give 0.5 milligram per body indocyanine green IV injection. So we see now clear margin on the spigot lobe and the caudal process, and segment 6 remnant and segment 6 subsegment, and also segment 7 and 8 border. Then first thing you have to do is superficial parenchymal transection using like that, ultrasonic decision. And G7 is divided, and the V7 is now clipped and divided. You see nice green shining area, that should be a remnant, and non-green shining area, it should be removed. So it's now clearly intersegmental sectional plane is visualized by IgG negative staining. So even sharp dissection is possible because in that intersegmental section plane, it does not contain any bile duct, any portal vein, any hepatic artery, any greason pedicle, only a hepatic vein running along intersectional segmental plane or crossing between the intersectional plane. So this is V7, and right hepatic vein is exposed on the remnant liver surface. Background is green, so it's a perfused area. Then segment 7, monosegmentectomy with segment 6, 1 cone unit subsegmentectomy has been completed. Amazingly, time is a little bit longer and blood loss is also good, but amazingly, pre-operative stimulation really close to this exact amount weight of resected specimen. So we hosted another important consensus meeting back in February, but online. So we invited the 37 liver experts, and we also did extensive systematic review. And this is a definition, a recommendation. We're going to publish Tokyo 2020 terminology. So definition, anatomical segmentectomy is defined as a complete removal of a territory of the third order portal venous branches of a cranial segment. So even with this definition, you can perform anatomical subsegmentectomy too. Following the appropriate intersegmental section plane is the key to perform a precise anatomical resection, which you've just shown from my video. And also the intersegmental sectional plane contains hepatic veins running along the plane or crossing the plane. So you can just focus to see a vein in intersegmental planes and not to bleed it. So we hosted International Liver Society World Congress in 2000, 2 years ago already in Tokyo with Professor Tanabe. It was a very good meeting, and over 700 people gathered, pre-Congress course, and even a lunch bento box. You sit next to each other without mask. So it was fun, and everybody looked happy. And it was kind of feel sad, farewell party in nice Japanese garden restaurant hotel. So I think I talk how I have come this far, but I feel like for young surgeon, I give this word: believe in your intuition, make friends, and continue. Then you will achieve it. Thank you very much for your kind attention.
Thank you so much, Dr. Wakabayashi. Chris, do we have him available? Can he see the stage? Can he see me?
Yes, but yeah, I can hear you. Yeah.
Dr. Wakabayashi, I'm holding up an award. It reads, to our 2021 state-of-the-art lecture in Miami Beach, Florida. Thank you, Dr. Wakabayashi. And we'll mail this to you via FedEx.
Thank you very much.
Well, we'll see if we have questions from the crowd, but Dr. Wakabayashi, to our junior surgeons that are watching your videos, it would have the appearance that liver surgery is bloodless surgery, where subsegmental Glisonian approach is just easily apparent in exactly where you put your instrument. So what would you tell the surgeons that want to start doing major laparoscopic resections? What do you think, from your experience, the literature and the international conferences, is the learning curve before you start doing major hepatectomy?
I think we've been discussing about the learning curve, but I think the learning curve is getting shorter and shorter because it's a video. You see a video, you learn a lot, and you share my video and my technique. So probably usually 20, 30 cases of a small hepatectomy you start major hepatectomy, then you accumulate more number with the major hepatectomy, then you go into the complicated resection, like I showed you, segmentectomy or subsegmentectomy. So I think for me, I'm a self-taught surgeon. I have to do more, but for young surgeon, probably 20 cases, 30 cases are enough to start a little bit difficult case.
Thank you. And I think we have time for one question from the crowd. I see Dr. Mariano Jimenez.
Well, hi, Go. Congrats for your amazing lecture. I love the photo of Iguazu Falls. My question is, what is your opinion, your expert opinion about the use of the ICG routinely? Is in all patients, only in patients with spreading parenchyma with anatomical resection, or in all cases, and the use of ablation?
Well, yes. Hi, nice to see you. I routinely use ICG now, so because I kind of become addicted, so I can't do any liver surgery without ICG technology. And as you know, you use ICG for ablation. Probably it works also good for ablation too. But you know, every liver surgery which I do is anatomical, but even without anatomic resection, you see shining tumor itself because we use ICG retention test a couple of weeks before the surgery. Then still liver cancer contain that ICG. Then you visualize the tumor itself. Then you secure surgical margin by ICG technology. So I think ICG is the way to go for liver surgery for next 5 years, 10 years in the future. And every surgery should use ICG, in my opinion. Thank you.
Thank you very much, Dr. Wakabayashi, for such an incredible talk and for sharing your expertise, which humbles all of us with your technical expertise. Thank you.
Thank you very much.